Hey guys, Woodruff here. So tonight we're going to start diving into the fun of lower gastrointestinal disorders. So this is going to include some common things like diarrhea, constipation, and we're also going to start getting into some of the other lower gastrointestinal disorders. This is going to probably be a two-part lecture because I have two different PowerPoints. And while these diseases aren't complicated, these can be a little bit longer. So I'm going to split up I want to say the crappy goodness, no pun intended, into maybe two fun long lectures. So this is a long lecture. They're smaller, shorter, simpler videos if you're looking for something that's more straight to the point. These are more for people that are wanting to go in depth or wanting to get the full lecture experience, which, power to you if you like that. So okay, let's get started. Oh, well, let's try to get started. All right, so the first disorder or disease we're going to talk about, really, I don't know if it's considered disease or disorder, but either way, it starts with a D and it's diarrhea. So you've probably never really sat around and thought about what is the definition of diarrhea. Believe it or not, the criteria for diarrhea is to have at least 3 loose or liquid stools per day. Diarrhea can be acute, where you're having, it for a short period of time, or it can be chronic, where you are long-term having issues with loose stools. It can, like when we commonly see, especially in acute cause, it's going to be from infection, especially different viruses and things like that. But it also can be caused by, foods. It can be caused by food intolerance and other GI problems. So generally what people are going to come in and complain about, they're going to say that they're having very large stools, very watery stools. They may also complain of cramping. The diarrhea could be accompanied, especially if it's infectious cause, with a fever or nausea, vomiting as well. So mostly with diarrhea, we don't sit there and do extensive testing. We may just do symptoms. But, especially if someone's had diarrhea for a few days and it's not getting better, we want to start looking at, is there an infectious cause? Is there an infection going on? So we'll do a culture to see, what's growing inside, just like we do for anywhere else in the body. We may get a C. diff to rule out that they don't have C. difficile, which we'll talk about as its own separate disease process. We may also get ova and parasites to see if there's a lovely parasitic infection going on inside. Additionally, we may get a CBC, specifically looking at the white blood cell count to see if it's elevated to show signs for infection. You also want to think about with diarrhea, they're losing on top of losing stool, in that stool is fluid. So we'd be concerned about dehydration. And one of the main, I don't want to say hallmark signs of dehydration, but one of the things we look for as a complication of dehydration is going to be altered kidney function. So that would be elevated creatinine. We also may look at electrolyte imbalances and acid-base imbalances. So if you remember, two things that we poop out are we poop out our base, we vomit acid, and we poop base. And so for when it comes to electrolyte imbalances, we poop potassium. So I always remember the double P. So we poop potassium. And so if I'm having a lot of diarrhea, regardless of the cause, I'm going to be losing potassium. So I want to keep a close eye on that because that can lead to my favorite, dysrhythmias and death. And I'm not saying that death and dysrhythmias are my favorite, but I love teaching about them. You would probably think that I do love because of the way that I talk about it, but I swear I'm not weirdly obsessed with that. So acid-base imbalances, we have to think about, okay, what's going on here? So with vomiting, I'm losing acid. So all I have left is base. And so what I have there is a metabolic alkalosis. So I always remember for vomiting, they're high risk for metabolic alkalosis. So I think of an alcoholic who is getting really sick and throwing up a lot. So metabolic alkalosis for vomiting. For diarrhea, it's the opposite. For diarrhea, I am losing base. And so I always think base comes out the butt. And so if I'm losing base, all I'm left with is acid. So I have metabolic acidosis. So as I talk about in my acid-base videos, what do you call it? Metabolic acidosis. When I have stuff coming out my ass, I have metabolic acidosis. And for those, this could be construed as profane. So, cover your children's ears if they're listening. But it's really just about acid-base imbalances. It's really not meant to be a profane thing, but people are easily sensitive these days. So what's my focus going to be for these patients? I'm going to be focusing on wanting to keep very good bowel elimination. So in other words, I want them to have normal bowel elimination. I want them to have normal stools. I also don't want them having a ton of stools a day, because it's those losses that are really going to be leading to a lot of the complications. Because if they're, again, we just went through this, if they're losing fluid, dehydration, if they're losing more base, they're going to become acidic. If they're losing potassium, they could get dysrhythmias. So it's really about stabilizing the consistency and also the frequency of their stools. So there's medications we can give, such as Pepto-Bismol. I'm not going to say the other name, but it is a aspirin product. So you want to, it has it's in the aspirin family. So you want to be concerned for aspirin toxicity. We may also give probiotics. And what probiotics do is they help to decrease what do you call it? Kind of rebuild the flora of good bacteria in your stomach. So those can be used, especially if it's something more chronic. We in more of an acute setting, when like they're having really, really frequent stools, maybe they're starting to get skin breakdown or have other issues. We want to slow it down. So we give things like Imodium or loperamide. The good thing about this is there's a less chance of them becoming dependent upon it. When I mean dependence is that this other one, also known as Lamodal, I'm not going to say the long name, it has some opioid properties in it, so it has more of a concern for dependence, like an opioid dependence, or it has more of an addictive quality to it. And there's more side effects because it has atropine in it, which is an anticholinergic medication. So we only use Lamodal, like, when it's more severe. But the one you're going to see most often on test questions and otherwise, it's going to be this one, loperamide, also known as Imodium. So what do you call it? What was I going to say? So backing up. So we can use Pepto-Bismol to kind of, slow things down, to like decrease secretions. It helps to thicken things up. We can slow things down with loperamide or Lamodal. And then, depending on the cause, we may use antibiotics as well if needed. And then we're just going to educate them, avoiding things that are irritating to them or leading to the diarrhea. Increasing their fiber can help to thicken things up where things are not so thin and watery. And then, like I mentioned, if you're having a lot of diarrhea, aside from the complications, the dehydration, acid-base, fluid, and electrolyte imbalances, we're also going to be worried about their skin, because if they're having frequent diarrhea, it can start to break down their skin. So monitor skin closely, use barrier cream as needed. All right, so let's talk about specifically C. diff. So this is also known as Clostridium difficile, and this is something that you'll definitely get to know. And eventually, after you've been a nurse for all, you actually be able to smell it from a mile away. Like, it's kind of a strange thing to have a skill in, but eventually as a nurse you can get the skill of being able to smell C. diff from a patient. Like, you can tell, like, hey, this smells like C. diff. But what you're going to look for, because you always want to look for cues in a question. So the cues you're going to look for that someone has C. diff is like usually in their story, they recently received antibiotics. So there's something in their story that, saying like, hey, they just had pneumonia, or they just had a UTI, or they just recently received a course of antibiotics. That's usually going to be your cue. This patient's going to be at risk for C. diff. Because what happens in C. diff, or what's going on, because let me finish this real quick. They also could just be immunocompromised or on chemo. But what's happening with C. diff is that, like I mentioned, there's good bacteria in the gut. So there's good bacteria that helps protect and do good things. But when I give antibiotics can really break down that good flora. So what happens is I take an antibiotic, it kind of kills my good gastrointestinal flora, or those good bacteria. And then what happens afterward is I end up with a different infection. So it's kind of funny, like I'm treating an infection with antibiotics, but I end up with a different infection from the antibiotics I gave for the other infection. So, but needless to say, it ends up with them needing antibiotics. So kind of a funny conundrum there, but it's different antibiotics, believe it or not. There's specific treatments that we do for C. diff. So we usually do metronidazole. I can never say that 5 times fast. I usually just say Flagyl. Remember, that's the one with that packaging that's stronger than any romantic relationship. And then the hallmark treatment, the one we usually do, is vancomycin, and we give it orally. So when we give vancomycin IV, it's more for systemic infections. But when we're giving vancomycin PO, or sometimes we can even give it rectally, we're trying to just get rid of that C. diff bacteria that's in the bowel. So we're trying to do more targeted, or think topical or local therapy. We also can do a fecal transplantation. If you didn't know what that is, you're in for a treat, because fecal transplantation is what it sounds. It means that they take someone else's feces, usually a loved one's, put an NG tube in, and they pretty much are taking that person's feces that hopefully has some good bacteria in it, and then they are sticking it into my body in order to think of it like fertilizing my flora. So that's the best way I can say it is if you know what the fertilization process is like when you're fertilizing plants, it's like doing the same thing. I am trying to replenish, reset down some good roots by transplanting someone else's poop inside of myself. So yes, that sounds disgusting, but somehow it works. This patient's going to be in special contact isolation. And what that means is that if there was a question that asked what kind of isolation they're in, they're in contact, but it's special contact because there's C. diff is so contagious. It will stay on surfaces for up to 70 days. So normally we use those purple top wipes, which are, just a disinfectant. But for C. diff, the only way you can kill C. diff is with bleach. So they have to do like a special cleaning procedures. You need to have bleach wipes in your room. And then using the hand sanitizer will not be effective to kill, C. diff as a bacteria. So you have to wash your hands with soap and water and wash them well to prevent the spread of this. Overall, for diarrhea, regardless of whether C. diff or not, our goals are to support hydration and nutrition. I want to monitor for all those complications I've already mentioned a few times. They may need ECG monitoring, like I mentioned, because of the imbalances, regular electrolyte checks, and replacing fluid and electrolytes. So if they're losing a lot of fluids, they may require, they may require, IV fluid replacement or electrolyte replacement, pooping out all the potassium. All right, let's talk about fecal incontinence. So at some point in life, all of us end up being able to be unable, or maybe I should just say being unable to hold in our bowels, or voluntarily have control of that lovely anal sphincter that we all have. The causes can be, maybe, like I said, there's a sphincter problem, the plug won't close. It could be a neurological problem, like a spinal injury or other damage to my spine or something, where it's not getting that message to stay closed. It can just be from time. It can be from strain, like childbirth. And it could be either the patient doesn't recognize they need they don't recognize they need to go, they cannot hold it in, or they don't even realize that they went to the bathroom. So overall, my goals for this patient is going to be to have adequate bowel elimination. And what I mean by that is that fecal incontinence can go 2 ways. So sometimes fecal incontinence can be just, loose stools, diarrhea, and stuff like that. So we could be worried about skin. But sometimes it can also be related to constipation, because sometimes what happens with fecal incontinence is they get what's called an impaction, which is where they have this wall of hard stools around in the rectal pouch. And then some loose stool starts sneaking around it, because there's just this wall, so some loose stool sneaks around it. So sometimes what we actually have to do is treat them like they're constipated. So when you see stuff here that you're like, wait, if they're incontinent, why would we increase their fiber? I'll explain that here in a second. But just know fecal incontinence, it could be diarrhea, it could be constipation. All that matters is that I'm sorry, I keep clicking here. All that matters is that they are having these stools that they're not in control of. So pretty much I want to, if it's a diarrhea thing, treat the diarrhea sometimes. If it's a sphincter thing, maybe fix the sphincter, or sometimes they end up with a permanent colostomy if there's a severe issue. Sometimes it's just about training. Maybe they don't know when they need to go, so we do a bowel program, or maybe we put a outside pouch or something else on them. Like I said, maybe it's constipation, they're impacted, so they need a suppository or an enema. or they might need like a box laxative, excuse me tonight. I'm just coming up with special words, laxative. Sometimes we can use that as well. And then, like I mentioned, skin health is going to be really big because no matter what, whether it's constipation, diarrhea, this patient is incontinent, they're losing stool. And so we want to monitor their skin closely, barrier cream. We want to avoid triggers. So things that might lead to higher chance of incontinence or things like caffeine or gas producing veggies. We're going to increase fibers and Kegels. And you're going to hear about Kegels a lot in this section. So what Kegels are, if you don't know, is where you practice contracting your pelvic floor muscles. And most people think Kegels for women, like after childbirth, to strengthen and keep things nice and fit and strong. But these are for men and for women. Both men and women can do them, and they help, to strengthen up the muscles there. Because remember, sometimes what can happen here is that if I have very weak pelvic floor muscles, I'm not going to have as much closure or good with I'm not going to be very good with keeping my sphincter well closed. And so Kegels can help to increase my ability to keep things it sounds weird saying nice and tight, but we really do want our sphincter nice, tight, closed. So to prevent incontinence. And then the other thing I'll mention is just, be kind because, this patient's already embarrassed, so don't need to make them feel bad because there's very few people. I mean, I've been a nurse. I always forget. Let's see. When did I graduate? Has it been? Oh, it's 10 years. Am I coming up on 10 years? I can't remember. I'm somewhere around there. I don't even remember anymore. Somewhere like 8 to 10. Yeah, I want to say it's 8 to 10 years. Maybe I'm at 10 years this year. Oh my goodness, 2000. Yeah, it'll be 10 years next year. It'll be 10 years next year. So anyway, I've been a nurse 10 years. And then before that, I was a tech for 10 years. And so as a whole, what I would say is that you want to consider that in that time, I have had maybe like 1 or 2 patients intentionally poop on me or poop just to be a jerk. 9 times out of 10 people are not pooping to be a jerk. They're not trying to make your life miserable. They're probably very embarrassed. They wish they couldn't do it. It's something out of their control or they are not with it. And I've worked at a lot of, county hospitals, other stuff like that. So I'm telling you, I'm working in places that if there was someone who was going to poop on purpose, be that. So in other words, but the key is here is just be kind, be nice. These are some different devices. This is what's called a fecal management system. Also might be known as a DigniCare, things like that, depending on your hospital. But it sits in the rectum, and you inflate a balloon, just kind of like a Foley. The things to know about this is that depending on your hospital facility, like the hospital I work at right now, they're moving away from using these for without they're being a little bit more strict about inserting them because we're starting to find that people that have them in long term are getting breakdown of their mucosa and coming in later with lower GI bleeds and stuff like that. So we're trying to be careful because it also can cause a patient to lose rectal tone. So if they really need it, if they're constantly draining, or maybe they have a lot of skin breakdown or have a lot of issues, temporarily this tube is great, but this is not meant to be a long-term fix, so I don't have to clean up my patient. And it's only helpful if they have purely liquid stools. All right, let's talk about the other side of things, which is constipation. So constipation, again, another thing you probably didn't think had a definition, which absolutely does. Constipation is infrequent stools, difficult to pass stools, or if they have a feeling of incomplete emptying. The common causes could be that the patient doesn't have enough fiber or that they don't have enough fluid. So they're either, not eating foods that are going to help to get things moving, or even if you're eating, good foods, if you don't have enough fluid, it's really hard to get things moving. Sedentary lifestyle, certain drugs can cause constipation and pregnancy as well. So the patient is going to be complaining, I have had no stools, that their stools are super hard. They may have difficulty passing their stools. They can also have abdominal pain, bloating, gas, and just a feeling of pressure in their rectal area. So this is the Bristol stool scale that you can use to kind of rate when you're charting. To see what the different consistencies can be for stool. So you can start to kind of become familiar. Most of them make a lot of sense when you're describing these. So what are the complications of constipation? Constipation complications can include that there is, there, because of the increased pressure, one of the things that can happen is like a varicose vein, but in your anal area, also known as a hemorrhoid, which we'll talk about later. But we're going to be worried about too much pressure in the blood vessels, like from the straining, the pushing, which can lead to hemorrhoids. Now, that's definitely not a fun complication. They're also, with really hard stool, they can end up with that wall of stool, also known as an impaction. They can have, from straining, perforation of the bowel, super serious. They can also have breakdown of the skins and tissues, which are called fissures. But I would say probably the most severe, like sudden consequence is what's known as vagal stimulation, aka passing out. So if you ever heard stories of a patient who was on their toilet or found next to their toilet passed out, a lot of times they were sitting there straining on the toilet. And what happens is that you have these beautiful baropressure receptors in your body. Cardiovascular system, by the way, has to own this. I love the cardiovascular system, if you didn't already know. And if you're my student and you're like, damn, won't this woman quit? I don't quit when it comes to the cardiovascular system, just like my heart will never stop beating until I die. But anyway, so the baroreceptors. So the baroreceptors are, what do you call them? They're there to like monitor pressure. So when there's too much pressure in my body, they say, hey man, too much pressure here. We need to chill out. And so what happens with vagal stimulation is that if I was having a bowel movement, I'm straining really hard, then all of a sudden my body senses the baroreceptors are like, hey, there's a lot of pressure here. Here, bro, let me help you out. And so it lowers your heart rate in order to like chill you out, to try to slow you down. But sometimes what happens, it lowers the heart rate too much, and then the patient passes out. Definitely a lot of stuff can happen here. You can have these uncomfortable, we'll talk about them, or possibly bleeding, complicated hemorrhoids. We can get impacted walls of stool. We can perforate our bowels. We can get skin and tissue issues, fissures, really uncomfortable. And then we can also pass out and die. And when I say pass out and die, they don't usually die. They usually just pass out. But, it's no fun to wake up with, and I'm not speaking from experience, but I did have a neighbor that this happened to. It's no fun waking up with, some handsome firefighters with your pants down, so, oh, my poor little neighbor. So anyway, again, our big goal here, just like I've already talked about for diarrhea and for fecal incontinence, is going to be that they have adequate bowel elimination. So I want them to be able to have, a soft form stool. And so we can do things like changing their position and providing for privacy and dignity. Because sometimes, there was one time I was sitting there with this patient, like they were a fall risk. So I wasn't about to leave them. I was a tech and I was sitting there with them. And I was like, okay, like just sitting there, la da da da, wait for them to poop. And then they turned to me after like 10 minutes and they were like, do you think that I can take it? Well, I won't say the words because, it's some people do get offended by profanity, but do you think I can sit here and take a poop while you're staring at me? And I was like, oh, when you've worked in healthcare for a while, you get so used to just sitting and watching people pee and poop and you start just talking about stuff. It's just like you're having dinner table conversation that you forget that most other people don't sit around with people in the room with them when they pee and poop. But yes, so also changing your position. I'll talk about this more, but there's certain positions that are more optimal for adequate bowel elimination. But then, of course, we always want to try least invasive first. But, when those things don't work, increased fluid, increased fiber doesn't work, movement doesn't work, all that stuff, then we start going into meds. And yes, there are more meds here, which I know you guys get so excited about. So some example of some laxatives. The first couple that I'll talk about are magnesium-based products, also known as saline laxatives. There's magnesium citrate. This is a very potent med. This is a bowel prep. So this is not for the lighthearted. And there's also milk of magnesia, which is not as strong. We use that commonly in the hospital. But the thing to keep in mind is magnesium and renal patients don't usually mix. So be careful if the patient has renal impairment. They want to avoid magnesium and aluminum-based products. So magnesium citrate, you might have heard of this. If you've ever had a baby, sometimes you get really desperate near the end and you really want to get that baby out. And some people do things like take laxatives and stuff, and it's supposed to help stimulate labor. It's not very safe from what I've been told. I'm not a labor and delivery specialist. The only thing I can tell you about labor and delivery is I do not recommend it unless you want the baby that's coming out and are ready for the rest of your life being surrounded around a crazy person. But all I can say about magnesium citrate is It's very potent. So it's not something that you take like just like, oh, hey, I haven't pooped since yesterday. Like this is more of like a last measure when we've tried other things, or sometimes we use it as a bowel prep before they're about to go to have like a colonoscopy. There's also one of the more common, like gentle ones, is what's known as polyethylene glycol, also known as Miralax. And so Miralax is, sorry, my cat's being a little needy. Miralax is something you usually, it's a powder, you mix it with some water and what do you call them? It's a gentler one, but we use it like we usually start with stool softeners. If those don't work, then we'll try some Miralax. If that doesn't work, we may try a suppository, so on and so forth. There's also Go Lightly. And so the name is very, very incorrect because there's nothing light, and the go part's correct. You're going to go. And so this is also another bowel prep. So just remember the go in it. You'll remember you're going to be going nonstop. Yeah, those are those two. There's also stimulant laxatives, and you're going to generally see, in general for constipation, giving a laxative is not your first intervention. You never want to do the laxative first. And I always hate to say never, because I'm sure there's some question your professors can come up with where it would maybe be the correct answer. But generally, especially with stimulant laxatives, those are, a later choice because we're really concerned about a patient becoming dependent upon them. When I say dependence, I'm not talking about like opioid dependence. I mean that just like anything, like if I had a Foley catheter in for a long time, my body kind of becomes dependent upon that. It becomes reliant on that. So in other words, if I use stimulant laxatives a lot, my body is going to require them to ever have a bowel movement, or always require them to have a bowel movement. Laxative in general, like we always want to do least invasive first. So in general with constipation, like I said, the first thing is not going to be like, hey, here, let me give some invasive medication. Let me try lifestyle changes and other things first. Because again, these medications, we don't like them long-term to be, having to stay on these medications forever, or having to stay on them long-term. Anyway, so stimulant laxatives are like suppositories, like a Ducalox suppository. They work rapidly and they cause contractions of the bowel and also lubricate. Like I mentioned, it causes that dependence. Probably one of the other things that we might use more on a day-to-day basis is what's known as Metamucil or psyllium fiber. This is just like extra fiber. So the great thing about it is it's a laxative, but it's not going to have the concern for dependence. You just want to make sure to mix it well because it's like a powder. So it's more of a natural way to go. For all these meds that are, oral meds and stuff like that, or the powders, we want to take with a full glass of water. Because again, like you can do fiber, but if you don't have enough fluids, the intake that you are, everything gets super thick. And all these medications will cause you to poop. So remember, think of all the things we talked about with diarrhea and incontinence, skin, electrolyte imbalances, dehydration, acid-base imbalances, all of it can happen. So just be aware, especially if they're doing a bowel prep, just be on the lookout. There's also enemas as an option, just depending on the patient, or how severe it is. You'll see these ordered, and yes, this is actually a real thing, the bucket and everything. It works really rapidly and helps to cause contractions in the bowels and helps to clear out stool that might be sitting there in the rectal area. But the patient you can give this to anybody, but for it to truly work, the patient has to be able to clench, because effectively what we like to do is we like to turn them on their left side. This helps promote motility. We infuse the water into their, rectal area, or like it'll be like the lower part of their colon. And then we try to we tell them to clench and hold it in for as long as they can, and then let go, because that's going to help it kind of sit to seep and kind of grab some of the stool that's kind of stuck or maybe hanging out in the bowels. Side effects, there can be inflammation or irritation because it's obviously a bunch of water. It can be a little bit rough, on the colon area. Water intoxication, so you can accidentally absorb too much of the water that could have sodium electrolyte imbalances, things like that. The things, you can actually get these over the counter. I'm not saying go try all of these, please Jesus. But these are things you can get over the counter, like fleet enemas. And what they are is, instead of like a big bucket, it's just like a small little bottle. You squeeze it, and it's very powerful and convenient. Other types of laxatives, saline, mineral oil, which is like a lubricant, or milk of molasses. It helps soften stool. So, I mean, you're not going to have to like to know the difference between these. Like, why would you use a saline versus a mineral oil? It's all just dependent upon the doctor, but it's good to know that there's different options. So overall, what are we looking at here for constipation? We want to protect their skin because from once we start giving them medications, things like that, they can start going. We kind of play this game in the hospital where we're giving them we're giving them medications to so we're giving them medications that are going to constipate them. Like maybe they're in pain, stuff's going on, they're going to get constipated. So then we're like, oh no, we need them to have a bowel movement. So we give them medication to have a bowel movement, and then we keep adding more and more and more until they poop, and then they start pooping a ton and they don't stop. So it's kind of this like continuous cycle that they're constipated, we give them a bunch of meds, then they're having diarrhea, then we stop the meds, then they get constipated again. So it's a balance. Let them know the risk of chronic laxative use. Like I said, they can have less tone and dependence upon these medications. So we want to avoid chronic laxative use whenever possible. And then the lifestyle modifications. So what's going on with their exercise? Get moving. Movement causes peristalsis, which allows our bowels to get moving. Enough fluid, enough fiber every day is so key. We usually like 20 to 30 grams of fiber a day. Do not wait. So a lot of times it puts a lot of pressure and creates issues with your sphincter if you're holding in your stools for long periods of time. Create a routine and a schedule. And then, like I said, about the position. So most people, let me see if I can get my mouse over here. Most people sit on the toilet this way. They sit like at a 90-degree angle. This is actually not an optimal position because it doesn't allow, it actually kind of creates a tension or a obstruction in the rectum where it makes it harder for stuff to slip out. So they have the beautiful squatty potties and other devices, or a lot of people just use stools. This is originally like the way that we were built as humans. We were meant to go to the bathroom this way in like a squat. And so this is a better way to allow for for stool to come out a lot easier. So try it sometime. This is something I would recommend trying. It may make a big difference. So this is a hemorrhoid. So hemorrhoids are swollen and inflamed blood vessels in the anal area. It's a result of too much pressure, like we talked about when we talked about constipation. It could be that the patient's sitting on the toilet for a long time. They have chronic GI problems, so they're on the toilet a lot. Obesity, pregnancy can increase your risk for hemorrhoids. Low fiber diet can do it as well. They can be internal or external, so they may be external like this one, or they can be internal. And patient may complain of itching, pain, bleeding accompanied with it. So overall, my priorities are to reduce the patient's pain and their symptoms. I want to soften their stool because it's going to lessen the amount of problems that they're having around their hemorrhoids. There's ointments and creams that can be used for the pain and irritation, like Preparation H. Sitz baths, which is like what this picture is showing, and it's where pretty much they do like Epsom salts and other things depending on what kind of issues that they're having. But you sit on the toilet it's like a little basin, and you're pretty much just like soaking your anal area, your buttocks in this little bath. It can help with comfort. So give them comfort and dignity. It's definitely not fun. Provide fluids and fiber, all the stuff. It's like pretty much like treating constipation, plus the fact that they have this actual hemorrhoid. So we treat the actual pain with that. And then there are like there is hemorrhoidectomies, and I talk about this when I get to hernias, but there's hemorrhoidectomies and there's also herniophories. I think that's how you probably say it. But so just be really careful when you're reading in your exam that whether we're talking about hemorrhoid problem or a hernia problem. But after a hemorrhoid surgery, overall, there's going to usually be packing in the rectal area. So we're going to maintain that packing. Our biggest concern postoperative for hemorrhoids is going to be bleeding. So we want to watch really closely that there's no bleeding. We're going to maintain that packing, control their pain, and they're going to get sitz baths as needed. And that sits best more long-term. Immediately, usually we just maintain the packing, and we're really trying to keep them from hemorrhaging and things like that, because it can be very bloody. The anal area is a very vascular area. We want to reduce straining, do dietary changes in order to let the fluids and fiber, and then activity and exercise, pretty much preventing constipation. So now let's start talking about some more serious stuff. I have acute abdominal pain. This is not like a syndrome or a specific disease, but it's really important to kind of note as we're getting into some other disorders that being able to do a good abdominal assessment is so key. So, when someone has acute abdominal pain, we want to think about what are some of the common causes, what are the other assessments, questions, and things I need to look for, ask about, etc. So common reasons would be any sort of inflammation in the bowels, peritonitis could be happening, an obstruction, or internal bleeding. The patient with their abdominal pain might have nausea, vomiting, diarrhea, constipation, gas, fatigue, and/or fever. So this is kind of this is a picture that kind of shows, like, you definitely want to know your quadrants, because we could have a test question that says, okay, right upper quadrant pain. You want to think about, okay, if it's right upper quadrant, what organs are there? So generally, we think right upper quadrant, we're talking about the liver, which we're not talking about any liver disorders. Hold on a sec. In my at this unit in my school, but could be talking about gallbladder problems. So usually think gallbladder problems, right upper quadrant. If it's epigastric, we're thinking about stomach ulcers, a GERD, things like that, gastritis. Left upper quadrant, we're talking about pancreatitis. We're talking about the flank area, we're usually talking about kidney stones. The left lower quadrant, it's about diverticulitis. Right lower quadrant, we're talking about appendicitis. And then I guess it would be the epigastric. I don't know exactly but in down in your, see, of course, like I sit here and I can get some sentences out for a while and then something come, just like that septum thing that I can't think of the word, but I will say the central lower portion of your abdomen, we are concerned about like urinary tract stuff. In the center, I would say like the only thing you really might have is like umbilical hernia, stuff like that. Now I know that there's talking about other ones here, but the ones that I mentioned is probably as deep for my school that you need to go. Because we do talk about some of the other ones of these, but we don't talk about all these things. So when we talk about their pain, we want details about their pain. When did it start? Where, like how long have they had it? Where on their abdomen is it? What makes it better or worse? Because does food make it better or worse? Does movement make it better or worse? Is there a certain position that they're in? Like a lot of times, like we'll see patients that have appendicitis and they're kind of have a knees flex position, because it really helps with some of their irritation and pain. So it can tell us a lot about how they're doing. We want to look at the contour of their abdomen, the shape. Is it flat? Is it distended? Is it rounded? Are they obese? Are there bowel sounds present or absent? That's super key, because there's very few times that absent bowel sounds are okay. Really, the only time absent bowel sounds are okay is immediately after surgery. But normally we should never have absent bowel sounds. Tenderness with palpation. So we, most of the time when nursing students do their assessments with me, my clinical students, they're always thinking that we're palpating to feel for organs. And if you're a nurse practitioner level, sure, you go and palpate those organs. We kind of are looking for masses, but 9 times out of 10, what we're really looking for is tenderness. Like, how does it hurt when I touch? And so you always want to ask about pain before touching. And when you're touching, you want to touch. And then, but if they're having pain, the other thing you want to see is we like to look for what's called rebound tenderness. And what that means is I am pushing down on the abdomen and it doesn't hurt when I push down, but when I let go and there's that rebound of the, like, whatever I'm pushing down on, it rebounds. That's when they have pain. That's what's called rebound tenderness. And that's a really bad sign. Rebound tenderness, think R is for really bad. We'll talk more about that. We also know what their abdomen feels like. Is it soft? It should be soft. If it starts to get firm, rigid, taut, we get a little bit, we get more concerned. An abdomen should never be rigid. So we do a variety of diagnostic studies. We can, of course, do a CT to see what's going on inside. We may get a KUB, a kidneys, ureter, bladder x-ray. It's just an abdominal x-ray like this. It can show us like gas and distension and stuff like that, free air. Ultrasound to look at specific organs. We may get a CBC to look for if it's infection present. on that white blood cell count. We can look to see if there's a problem with certain organs, like we will get an amylase or a lipase if we were looking at the pancreas. We'll talk more about pancreatitis later. And we want to see maybe is there a problem in the urinary system. We may get a urinalysis. We also might want to rule out pregnancy, and you'd be surprised how many people can be very pregnant and have no idea they're pregnant. So overall, patients that are having abdominal pain, again, depending on what the cause is, they can have a lot of instability with their abdominal pain. So I want them to have stable vital signs, hemodynamics. If they're having what we call an acute abdomen, they're going to need surgical intervention, or not they're going to, they may need a surgical intervention. So they may need to be NPO, NG tube, IV fluids. They may need oxygen to help support them. Again, all just per physician order, and close intake and output management, and then assess any sort of M.H.D.R.C.R.D.H that the patient may be having. Symptom management, frequent pain assessments, pain management, also antiemetics. If they're vomiting, good oral care. Post-operative early ambulation is key. These patients are not going to want to feel like walking, but after having abdominal surgery, especially if it's laparoscopic, we retain, like, they literally infuse us with CO2 and they like inflate you, and so people can have a lot of gas pain, and so it's key to get up and get moving. Now they're not going to want to feel like getting up and get moving, but they need to so bad. We want to also prevent complications of immobility if they're more immobile. So now let's talk about gastroenteritis. So it has the gastro in it. So you're probably thinking, oh, she's back to talking about the stomach again, but I'm not. Hold on a second. And so gastroenteritis is actually a inflammation of the stomach and the small intestines. So when you think of like a stomach bug, or like, hey, my kid has a stomach bug, or I have a stomach bug, this is usually what we're talking about. It's usually a virus, and it's different than other things we've talked about because it's usually sudden. There's sudden diarrhea. It also can be accompanied by some of those upper GI stuff like nausea, vomiting, fever, cramping. We're going to treat it similar to a patient with diarrhea because this is a lot like infectious diarrhea. We're going to replace fluids. We definitely want to make sure they're getting enough glucose and electrolytes in for those losses. And if they can't take PO, and they may need to go to the hospital to get IV fluids, but otherwise it's usually pretty self-limiting. Now let's get into one of the big guns. So there's a lot of different diseases with lower GI. Let's start getting into some of these. So the first one I'm going to talk about is IBD, also known as inflammatory bowel disease. At my school, you only need to know about IBD. You do not need to know about IBS, which is irritable bowel syndrome. But inflammatory bowel syndrome is really common, and when it's very common when it comes to GI disorders, like it's one of the more common ones that you're going to see in the hospital. And there's two different disorders that are under inflammatory bowel. There's what's known as Crohn's disease and then ulcerative colitis. So these two are similar, but a little different. So what I'm going to hopefully get through in the next slide or two is what are the differences here. The key thing is both of these are considered like an autoimmune or an immune-related disorder. The body's attacking itself. So both of these, they go through periods of remissions and exacerbations where it gets better or worse. Risk factors are going to be, genetics, diet, stress, smoking. Smoking is horrible for the GI tract, just like it was horrible for the beautiful cardiovascular system. General symptoms they might have with this, diarrhea is going to be one of the most common things. As we're getting into lower GI, you're going to still see some nausea, vomiting, but you're also going to see a lot more of the pooping problems because we're getting into lower GI. So probably the most characteristic sign of inflammatory bowel is diarrhea. They can also have abdominal pain, fever, and fatigue. So the first big difference here, here it's kind of showing some pictures. There's a healthy colon, there's ulcerative colitis, and there's Crohn's disease. So there's a few differences here. So Crohn's disease is a inflammation, just as the name would suggest, that can happen anywhere in the bowels. So the thing that makes it different, it can happen anywhere in the bowels, all the way from the esophagus, stomach, all the way down to the colon. Whereas ulcerative colitis, as the name suggests, is just in the colon. The other difference is Crohn's goes deep. So it goes deep into multiple layers of the bowel, where ulcerative colitis is just on the surface. So think ulcers on the surface of the colon, so ulcerative colitis. Whereas Crohn's, it's an equal opportunity employer. It's going everywhere. It's going deep. And that's why some of the symptoms are a little bit different. So Crohn's disease, they're more at risk for malnutrition and weight loss. Excuse me, and can have more like the systemic, like really deep, like fatigue and other effects. And a lot of that has to do with the fact is you have to think about where it happens. If Crohn's disease can happen anywhere in my bowel and goes really deep, it can happen in my small intestines where a lot of absorption happens. So with Crohn's, I'm really worried about nutrition. I'm worried about, that weight loss and that cachexia and other stuff that can happen as a result, because literally they're getting inflammation in the part of their bowels they need for absorption of nutrients. Ulcerative colitis is different because it's just in the end part of the bowels. I'm done absorbing nutrients. So these patients usually don't have as much of the weight loss, but they are more at risk for, remember how vascular I told you the colon area and near the rectum is? So they're just having tons of bloody diarrhea. They tend to have more stools per day. And I'm much more worried about blood loss with them. Crohn's disease, they can have some bloody stool, but it's more like, I think, Crohn's disease, like malnutrition, absorption issues. Ulcerative colitis, I think of inflammation in the colon, bleeding, and risk for more of those losses. This kind of gives you a picture. So like you see here in Crohn's disease, it's what's called patchy inflammation. So they come in patches, whereas you see ulcerative colitis is it's continuous. So think, well, I guess they both have C's in them. So yeah, I always try to make mnemonics, and sometimes my mnemonics or my little word plays just don't always work. So Crohn's disease, patchy. Ulcerative colitis is continuous inflammation just in the one area, but you can see it goes all over the place. And like I said, Crohn's disease, it affects all the way to like all the layers of the bowel and can even go to the outside here and lead to a lot of issues. Whereas ulcerative colitis is just in that inside, leading to like irritation, inflammation, and breakdown, which can lead to bleeding. So how do we diagnose this? Most of the time we have to diagnose this off symptoms and also ruling out other problems. We can do things like do a barium enema or a colonoscopy, because again, usually this affects the lower end of the bowel. But how do we do it for Crohn's if it's in the small intestines? Because there's only so much. Most people would probably say endoscopy. An endoscopy can only go so far. It can't go into the small intestines, and then a colonoscopy can only go up so far. So there's like a period in between. It's like, how do we see inside that bowel? So there is what's called a capsule endoscopy, where you swallow a capsule that has a camera in it and it goes through your bowels and can take pictures. We may do a biopsy of the tissue to see what's going on. And then we're going to do labs. So keep in mind, generally, like a hemoglobin greater than 12 is normal. We don't usually transfuse till it's less than 7. But we're going to look for bleeding, and especially we're going to look for bleeding if we're suspecting ulcerative colitis. We may look for infection, do a white blood cell count, kind of ruling out other problems. We're definitely going to look, just like we did with rheumatoid arthritis, we're going to look for inflammation, that elevated CRP and ESR. And then we also do schools, apparently, again, as some people in my class would say, I need to go back to school to apparently learn how to talk too. Stool, specimen, and culture. So if you can notice, yet again, my priority here is adequate bowel elimination. So I want to decrease inflammation, make sure that they are, so let me back up here. To have good bowel elimination, to cut out this diarrhea, because with Crohn's and ulcerative colitis, they're having diarrhea. With Crohn's, they're having diarrhea. It may be less frequent and less bloody, but they're having diarrhea. With ulcerative colitis, they're having more frequent diarrhea, and it's usually bloody diarrhea. But for both of these, there's diarrhea. It's the hallmark symptom. From a lack of, because of the result of the inflammation. So I can sit all day long and treat the diarrhea, but until I get to the bottom of the cause, which is that there's inflammation in my bowel, nothing can get better. So there's a special type or class of drugs that we use for inflammatory bowel disease known as 5-ASA. It's not actually an NSAID, but it's in the same class as aspirin. But it works differently. The whole purpose is to decrease inflammation in the bowels. And the best way that these are absorbed, they can be given orally, and they are given orally, but they're best absorbed topically. So we usually use them in ulcerative colitis and give them via enema or foam. We can also use things like steroids, because remember, these are autoimmune or immune-related disorders, so they're going to help to decrease the immune system. But keep in mind that on the flip side of things, I'm worried about their immune system being suppressed, and then risk for infection. And then also remember, steroids always think steroids, hyperglycemia. We can give these steroids for ulcerative colitis, suppository enema, foam. We do oral or IV, and we worry more about the immunosuppression, the hyperglycemia with the oral and IV. But it can potentially be absorbed otherwise. Usually, if you're given something suppository enema foam, it's mostly topically working, but it's always possible for it to be systemically absorbed. But especially if they're getting oral steroids or IV steroids, I'm going to be really concerned about their blood glucose, and I'm going to be concerned about their immune system. As with all steroids, they must be tapered. So we also, of course, because like I said, this is a disease that has exacerbations and remissions, that we want to decrease the amount of attacks they're having, the amount of inflammation that's happening on a regular basis. So we also will do things to prevent them from having flare-ups, like give them immunosuppressions, biologic agents. These help prevent attacks, but they also suppress your entire bone marrow system. So we're going to need to, like what we call myelosuppression or bone marrow suppression. We need to monitor the CBC and monitor those labs to make sure that they're not having severely low levels. We're also going to be concerned about their risk for infection. So we're going to, do good hand hygiene, avoiding crowds, make sure they stay up on their immunizations, avoid sick people, things like that. And then surgery-wise, a lot of these patients end up needing a bowel resection. Some of them end up with colostomies, things like that. Sometimes eventually they get to the point, especially with ulcerative colitis. No, sorry, I said it backwards. A lot of people with Crohn's end up, having multiple resections and then having like short gut syndrome where they don't have enough gut, and they end up with like enteral nutrition, parenteral nutrition, colostomies, and stuff like that. When it's severe, that can happen. I'm not saying that happens all the time, but it can happen. So I want to prevent complications with these patients too. So I'm worried about with inflammation that there's going to be bleeding, and bleeding can obviously lead to some hemodynamic instability. There also can be perforation. So we talked about those 3 P's before, that there's the pain, perforation, pain, perforation, peritonitis. I said it right. Okay, pain, perforation, peritonitis. So there's pain from inflammation. Inflammation leads to perforation or opening. And remember, the bowels are not a clean place. So when they perforate, then it can lead to sepsis, peritonitis, and death. They can also get infection, C. diff, or this is a picture of toxic megacolon when the colon just gets super wide. You can see how hard this would be to get this back into a patient. And then also, and by the way, this is not a human's colon, just in case. I know you're sitting here saying, holy crap. I always get my students with this. So if you're watching this ahead of our lecture, act surprised, because I always love showing off this picture, but I'm pretty sure this is a horse's colon. Hopefully they can get it back in, but this is a horse's megacolon. If it makes you feel better, it's not just any colon. They also can have a fistula, which we'll talk about fistulas later. So actually, we're going to talk about fistula soon, it looks like. Other complications are going to be things like peritonitis, which I've been talking about a lot. This is the infection that happens in the peritoneal cavity around the abdomen. So this is obviously meant to be a clean area, but if there's that perforation that happens or leakage of fecal contents out here, they can end up getting like sepsis, and it's a very high chance of death. When someone has an acute abdomen, like if I get a patient, they're going and they have dead bowel or they have peritonitis, it's really hard to keep everything clean and get things cleaned out. So very high risk of death. We need to be super careful and catch this stuff early when we can. So like I mentioned, those hallmark signs, that these are like your warning, your worst signs. This is never going to be okay. Rigid abdomen, never okay. Pain in the abdomen, okay, they could have that. But rigid abdomen, no. Rebound tenderness, never a good sign. That's the thing. We push down and it bounces up and it hurts when it bounces back. That's a sign of peritoneal irritation. Fever, we definitely want to look into. They can have nausea, vomiting, and that, again, another really big warning sign, absent bowel sounds. Patients with peritonitis, we put them on suction, give them parenteral nutrition. We want them to be NPO because we do not want to do anything to agitate or further worsen that perforation or whatever had happened. Good fluid and electrolyte balance, antibiotics, antiemetics. They're probably going to need surgery to repair any damage, drain any nasty fluid that's coming out. And then a lot of patients with abdominal issues feel more comfortable side lying, knees flexed, positioned, and then they may need other pain relief as well. Like I mentioned, there's also a risk of fistula. And so fistula is where there's an abnormal tract or opening between two organs or between an organ and the skin. So this could be, sometimes I've seen fistulas in between like the anal area and the urethra. You can see here in this picture, there's some between the intestines and the outside. But pretty much what you're going to notice with the fistula is that in an area where there's supposed to be a certain color fluid or something coming out, something very different is coming out instead. So this would be like I had a patient who was peeing, but poop was coming out of their urinary tract. So I was like, wait, what's going on here? Or someone has out of their abdominal area, they have some like urine seeping out from their abdomen. You're like, wait, this is not supposed to be here. It's usually because there's like a weakness in the tissue, and it might be because they've had multiple surgeries, they have a GI disorder, they had trauma, cancer. It's really common for them to get fistulas, just because the weakening of the tissues and things like that. They may have a fever, abdominal pain, but the big hallmark here is going to be some drainage of pus, urine, or feces, and it's usually in a place where it should not be leaking that. Oh, well, excuse me. Sorry about that. Treatment, we want to prevent infection because obviously stuff's going where it's not supposed to go. And they also can have breakdown of their skin from the leakage. So monitor their skin closely, maybe give antibiotics, other treatments as needed, fluid and electrolyte balance. A lot of times we keep these patients NPO because especially if it's their bowels or their bladder that's going, a lot of times it can worsen things to be feeding them and stuff like that, but it just depends on the patient. Most heal on their own, but some may need surgical closure. Other priorities in education we want to do for inflammatory bowel disease, we want to support nutrition, do daily weight, especially with those Crohn's patients. We're going to do what's called a low residue diet. I'll talk about that on the next slide. We're going to keep their skin clean and dry because remember, diarrhea is a big issue for these patients. Additionally, we want to maintain their comfort and dignity. This is a chronic condition, so we want to try to help them best we can to live as normal of a life as we can help them with. And just reminding, educating them that, things like that are going to exacerbate things are not getting enough rest, that's too much stress, and how to take care of themselves. So general stress management is super important for these patients. So that low residue diet. So when you think low residue, think low fiber. So residue is like leftovers in the bowels. And so when there's a bunch of leftovers of like stuff is just chilling in the bowels, there is like with more residue, you have stuff left over in the bowels, which leads to, if I have stuff just chilling in my bowels, I'm going to have more irritation, inflammation. If I already have an inflammatory bowel condition, I don't want that. So I want less residue, less stuff hanging out. So this is one of the few times like we want a high fiber diet. So sorry, I said it backwards. Sorry, a low fiber diet. Like most of the time we always say high fiber, high fiber, high fiber, but this is probably one of the only times. I don't want to say that I'm pretty sure it's one of the only. There's one other time when we talk about diverticulitis. When we talk about diverticulosis, we like high fiber, but diverticulitis, they're NPO. So yeah, we'll talk about it. I don't want to get you too confused, but this is the main patient that when we talk about a low residue diet. So think low fiber. So we actually like everything that's white. So good foods are going to be like white breads, white rice, low fiber cereals, pasta, meat, fish, eggs. We really want to avoid anything that's whole grains, anything that's nuts and seeds, fruits, or vegetables. I know that's going to seem very counterintuitive, but again, we don't want to put anything in their bowels that's going to lead to inflammation and irritation. So that's the first half of my GI lecture. Next, we're going to start going into ostomies and other things, and then we'll get into some other GI disorders like the diverticulosis, diverticulitis. We'll also get into some of the appendicitis, the gallbladder disorders, and pancreatitis, chronic and acute. I hope this helped, and I'll see you for the next one.